Thank you, Professor. Good morning. Today I'm going to make a presentation on phenotyping. Well, in order to have appropriate results from pharmacotherapy, the first one is to check the blood medication measurements. The other one is genotyping, and the other one is phenotyping. Genotyping was the topic of the other presentation. Phenotyping is also providing practical information in clinic, and it's also a cheaper technique. In fact, when we look at these three methods, so they have advantages and disadvantages when compared. But in clinical practice today, there was a case at our hospital. The patient is using SSRI, but the biggest problem is the numbness in the hairy skin. There is burning sensation in the whole body, and there is also itching. And also the person is crying all the time. The person is very depressive, and the patient has great fatigue. Venlafaxine was used up to 225 milligram of dose, and the TDM was at the therapeutic interval, but there was no clinical response. Duloxetine was thought as a result of the duloxine, and from 30 milligrams up to 60 milligrams doses are used. And in the first periods, the patient said there was no effect and the symptoms continued. But just partially, the person was waking up in a much better way. Then there was, in that case, you have the tendency to increase the dose of duloxetine, or you can add on a treatment. So duloxetine TDM follow-up was performed, and in the TDM, duloxetine was at the upper threshold, not very high, but towards the upper threshold. So there was no alert situation in TDM. We asked for phenotyping, and in one, a kinesin level was a poor metabolizer, so the metabolism was slow. In the TDM, of course, it can be at the upper levels, upper threshold levels, and we think that there's a clinical picture, but it's the poor metabolizer, and it shows that you can see a toxicity in this table. So we reduced duloxetine to 30 milligrams and then to 15 milligrams. And you know from your own practice that by means of this 15 milligrams would not reduce the symptoms of this person. But the person got much better with 15 milligrams of duloxetine. Therefore, phenotyping is providing great information in our daily practice. And also, the drugs are effective in the central nervous system. They have lipophilic characteristics, and they are binding to small molecules. The liver microenzymes are the areas where they metabolize. The liver enzyme system, metabolization characteristics and phenotyping are very important for the drug-resistant patients. And approximately 20 to 40% of these patients are explained by these liver microenzyme systems. And if we know this liver enzyme system, then it's very probable that you can have a solution for the patient. It's more comfortable for us, and the treatment will be more reliable for the patient. There are 4 types of phenotyping. One of them is the ultra metabolizer. The other one is medium metabolizer or poor metabolizer. If the patient is a poor metabolizer, then the drug will be metabolized in a slower way, and the drug cannot be cleared out from the body, and you will see toxic effects. If there is ultra metabolizer, then the plasma levels in the blood will be reduced, and you will not get the benefit from the drug. It will be cleared out the clearance will be very rapid. In phenotyping, there are some advantages. Yes, I talked about the 3 methods. Genotyping is one of those methods, but it has a disadvantage. For instance, for CYP2D6, in 2D6, there are more than 70 alleles, and it's very difficult and expensive to check all the alleles. Therefore, the most frequently seen alleles can be checked in terms of genotyping, but if there's a polymorphic change in less frequent alleles, then genetics will mislead us. And when we look at the genetics of that sample, that's a case example, it looks as if it's a poor metabolizer, but normal metabolizer, sorry, but in fact it was a poor metabolizer. And also there are some different effects, different factors affecting the activation of the gene. Therefore, phenotyping is actually including the genotyping, and it is showing the metabolic capacity for a variety of drugs. In addition, the drug combinations are also important in phenotyping. You can also detect the interaction with the co-administered drugs. For instance, hepatic failure and about renal failure, you can also have some information in the metabolic pathways, because phenotyping provides that information. Of course, I talked about the advantages, but what are the limitations of phenotyping? It's a practical method. However, you need to give a drug. You need to test a drug. And of course, there might be some side effects of that substance to the person. There can be some ethical problems. You also collect samples, particularly for 2D6. You collect urine for 2 hours. And it provides information about the metabolic pathway of the drug, and you make an estimation in the end. In the psychiatry, most of the time we are using CYP2D6 phenotyping, and this is the enzyme system which metabolizes most of the drugs that we use. The gold standard is the method as follows. Dextromethorphan is transformed to dextrofan through CYP2D6. Therefore, when we give dextromethorphan, we can see which amount is metabolized to dextrofan and which has metabolized in the body. So we can make the assessment here. We do not give a diet, but just 30 milligrams of single-dose oral dextromethorphan is given, and we collect urine for 8 hours, and we see we have a cutoff value separating poor and extensive metabolizers. This is 0.3. And debrisokin is also checked in terms of hydroxylation. And in metabolization, we do not have very distinct characteristics. And 2D6 is induced in debrisokin. That is why the inhibition is still there. Therefore, we use mostly dextromethorphan instead of destricoin. In 8-hour urine collection, we use a cutoff value. And again, dextromethorphan is checked in terms of its rate to DOR. If it's less than 0.003, then it's ultrametabolizer. And if it's over 0.3, then it is a poor metabolizer. Another phenotyping is 1A2. We have the gold standard of caffeine. The phenotyping of 1A2 is different from 2D6. In 2D6 you administer 30 milligrams, but here we implement a lower dose. But sometimes diet can be asked. Diet can be given, but also we can say that this is an easy technique. And then on the 8th hour, the blood samples are taken. The caffeine has 3 main metabolites, Every laboratory has its own technique. Most of the time we use paroxantin, and 1A2 phenotyping is done accordingly. There are some other substances like tolbutamine, warfarin, and losartan. And also we have another enzyme system which is 3A4 phenotyping. 3A4 phenotyping is mostly used in erythromycin inhalation test, and the carbon dioxide is checked in inhalation, and midazolam. If you administer midazolam IV, through IV, then the liver enzymes are also shown, and the metabolic pathway is shown. But if you administer it orally, then intestinal 3A4 is analyzed. So this is a one single probe drug. This is the phenotyping of one single drug. And also there is a phenotyping study where we have more than one substance. The advantage is that, for instance, when you give one substance, you see one single enzyme. However, in order to make it more practical, if you co-administer a couple of substances, we may be able to see more than one enzyme. Cocktail approach is not so frequently used. The reason for that is the ethical reasons, because there are some side effects of these substances, and they may have some interactions, and they may change the metabolic pathway. So there is a lack of reliability of this method. So in the last decade, cocktail approach is not very well adopted. For instance, these substances are given through certain pathways, and according to the metabolization pathways, blood or urine samples are collected, and you check the metabolites, and you can understand whether the enzyme system is functioning normally or poorly. Again, this is summary. When you said you should finish, I was just inclined to finish. So phenotyping is a technique that we use in our clinical practices right now. It is just like genotyping and drug analysis, blood drug analysis. Of course, there are some researches on genotyping, but phenotyping is more practical. According to 2011 guidelines, genotyping is used only if phenotyping is used only if there is a great side effect of the drug, and if there is a therapeutic interval which is very short, then phenotyping should be used, and only if the phenotyping would be very detrimental in terms of side effects to the person, then genotyping is recommended.